care of pregnant people. So knowing the basics of maternal health is important, right? We're creating generalists in this program. I'm not here to create OB nurses, but I do hope the information that you take away from this class you can apply in the future. Med-surg patients come postpartum all the time with mastitis and need IV antibiotics. I send patients in DIC to the ICU, right? I send patients who are in sepsis to the ICU. I put NG tubes in on pregnant women. So just because they're pregnant doesn't mean they're not sick, right? And actually the way things are kind of progressing, pregnant people are sick. We see more hypertension than we ever have, more gestational diabetes. So there's a lot more complications in pregnancy than we have previously seen. Why?
Because nobody can get health care.
Yeah, healthcare, our diets, right? There's so many toxic things in the food that we eat nowadays that weren't previously there, that are increasing our blood pressures, just anything and everything. But maternal morbidity and mortality have definitely risen. So just know, even if you're not interested, be open to learning, because it could be applicable. I had to go in and do fetal monitoring on a patient who was having pins placed in her ankle because she broke her ankle during pregnancy, right? So people have to have surgery. People have to have their appendectomies during pregnancy. So just know, just because you're not an OB nurse, you'll probably take care of someone pregnant or postpartum at some point, right? So that's my little soapbox about that. Any more questions before we get started? Are you guys just terrified? Yeah. You'll be fine. You'll be fine. Nothing scary here. I will say I do need to get a clicker because this is a really long classroom. I need to invest in a clicker. So maybe in 2 weeks I'll have a clicker when you come back. So we're going to talk today about presumptive, probable, and positive signs of pregnancy and what those look like. Describe maternal changes, just overall changes during pregnancy, and there's a lot of changes. Summarize the nutritional needs of someone who's pregnant, and characterize the emotional and physiological or psychological changes that occur. This is a big adjustment, getting pregnant and bringing home a baby. So again, we're going to start with these signs and symptoms of pregnancy. How do you know you're pregnant? Take a test, right? But do you think a test is a probable, a positive, or a presumptive?
Probable.
It's probable, right? Why do you think it might be probable?
Because you could have, cancer, or I forget what it's called, but it's where you have cysts.
Mm-hmm. Yep, there's other things that produce these HCG, and that's what that test is looking for, is an increase in HCG hormone in our blood vessels, or bloodstream. I had to Google this. Baking soda test. Has anyone ever heard of it?
No.
Yeah, neither did I, so I Googled it. But apparently, it's very presumptive. If you pee in a cup and, the acidity of your urine increases during pregnancy, you throw the baking soda in there and it starts to fizz. Very presumptive test method of pregnancy, right? All right, so let's talk about these a little bit more. Presumptive signs and symptoms. So these are perceived symptoms that the woman is associating with potential pregnancy, but you can't confirm it, right? So amenorrhea, what is that?
No period.
Yep. And then fatigue. Got 12 weeks listed up here. That really sets in at 6 weeks and just doesn't let up, I think. Breast tenderness, that's going to be one of your earliest signs, changes in your breast tissue and breast tenderness. But again, breast tenderness could be coming from what? Could be coming from period, could be coming from some sort of contraception that you've been taking. Nausea, vomiting. It's normally a pretty good sign you might be pregnant, but again, could be related to something else, right? Urinary frequency, this is a common side effect of pregnancy that you're going to see about 6 to 12 weeks because of that pressure on the bladder. And we'll talk about that a little bit more. But urinary frequency can also be chalked up to UTI, right? Hyperpigmentation of the skin, so seeing some skin changes. Fetal movement or quickening, somebody could say, oh, something, is moving in there. Like I swear, they say it's not real, but I swear it is real. Phantom kicks, if you've ever been pregnant, like having phantom kicks afterwards. Like I think it's a real thing, but they say it's not. But I think it is. Your uterinal enlarge, and again, breast enlargement as well. So those are all presumptive signs, subjective signs that we could look at and be like, oh, maybe I'm pregnant. Yes.
Do we know the time frames of these things?
No.
Okay.
I mean, no, like early, middle pregnancy, late pregnancy, something like that. But I would never ask you at what week.
Okay. Yeah.
What? Yeah. All right. So probable signs or objective signs of pregnancy. So these are normally something that a healthcare provider is going to find on their exam of you. Findings are usually present due to pregnancy, but can be related to patho, where uterine size is altered or HCG is present. So potential probable signs are Braxton Hicks contractions. So those are those practice contractions. So once the woman's uterus has enlarged, it's going to start practicing. So it's going to do practice squeezes to prepare for the big squeezes later on down the road. Then we have positive pregnancy test. We're going to have abdominal enlargement. Something called Bellotment sign, Goddard sign, Chadwick sign, and Heger's sign. And we're going to talk about those. So bellotment is when a provider is actually doing a vaginal exam or cervical exam and can feel the fetus bounce. So they touch the cervix, this being the cervix, touch it, kind of push, and you can feel the bounce of the baby's head. Then we have Goddard sign or Goodall sign. This is the softening of the cervix. So the cervix, in order for it to dilate when you go into labor and get to 10 centimeters, has to soften first. So normally your cervix is really long and firm, kind of like a forehead almost. This will be a lot softer. Then we have Chadwick's sign. And because of increased vascularity, the cervical mucosa and the vaginal mucosa kind of get that purple bluish tint to it. And Heger's sign, which is the softening of the lower uterine segment.
I have a question. What would be the stripping of the membrane? Is that one of these signs?
No.
Okay.
No. That's way down the road.
Okay.
Yeah. All right, so pregnancy test. Again, this is a probable sign. So an HCG level lower than 5 is considered negative for pregnancy, and anything higher than 25 is considered potential for pregnancy. So this is the earliest biochemical marker of pregnancy that you can get. And HCG stands for human chorionic gonadotropin. It's a big word. So HCG levels in normal pregnancy usually double every 48 to 72 hours. So let's say a patient comes into their first OB visit or a very early OB visit and say, I had a positive pregnancy test, but I don't know when my last menstrual period was. I don't know if I'm pregnant. And they get an HCG that's really, really low. Let's say maybe 30. The provider will say, come back in 2 to 3 days and we'll redraw it. And we should see that number have at least increased to over 60 right? Should be 90, something crazy. And then it actually peaks at about 60 to 70 days after conception, and then it's going to start to decline. So a woman who's almost 40 weeks pregnant could take a pregnancy test, and it could come back negative because that HCG level is going to decrease. Although pregnancy tests are used to establish the diagnosis of pregnancy when the physical signs are still inconclusive, they are not completely reliable. Other conditions such as ovarian cancer, choriocarcinoma, can also elevate your HCG levels.
What did you say the minimum number is? For
25.
Or the minimum is?
Or if it's 5 or below, definitely not pregnant.
Okay.
Yeah.
Okay.
So then we have our positive signs of pregnancy. If I see the baby, I know I'm pregnant, right? So that ultrasound, going and having that ultrasound done. Says 4 to 8 weeks here. Really, a lot of times OB providers will do ultrasounds later on, but they might try and do a Doppler tone, or they're doing the blood HCG test and telling you to come back about 12 weeks for your first ultrasound. And a lot of times they don't like to do ultrasounds that early because you can't always see baby's heartbeat at that time. So being able to tell if it's a viable or non-viable pregnancy is difficult that early on. Not a test question, just for your information. Additionally, palpation of fetal movement by a healthcare provider. That is a positive sign. And then auscultation of the fetal heartbeat via Doppler. So a Doppler. All right. So every system of a woman's body changes during pregnancy to accommodate the needs of the growing fetus. And those changes occur at startling speed. So it can happen fast. And it seems like it happens faster with subsequent pregnancies than with your first. The physical changes of pregnancy can be uncomfortable, though every woman reacts differently. So just because I had some sort of problem during my pregnancy, Kim may not have had that same exact or issue in her pregnancy, right? Everyone is different. No one size fits all. So this little cartoon's funny. How is this pregnancy going, dearie? Oh, just fine. If I could ignore the backache, constipation, heartburn, nausea, vomiting, acne, achy feet, incontinence, exhaustion, varicose veins, stretch marks, moodiness, and nosy strangers. Right? Because when you're pregnant, everybody wants to ask you questions or touch your belly. Get away from my belly.
I don't think I've ever done it.
Touching someone's belly?
No, absolutely not.
Yeah.
No.
The lab tech, if you guys didn't know, the lab tech Elise is pregnant. She's due in November.
Because, what if they're not
All right.
Right.
So let's talk about pregnancy hormones. Hormones play a huge role in pregnancy. And there's a lot to know about these hormones. So again, HCG, that's that one that is going to tell us if we're pregnant or not, right? Responsible for maintaining the maternal corpus luteum, which secretes our progesterone and estrogen, with synthesis occurring before implementation. It's produced by the fetal trophoblast cells until the placenta is developed sufficiently to take over that function. So eventually, the placenta will start to secrete these. It's the basis for early pregnancy test. Again, as early as 8 days after conception, we can pick up HCG in the urine or blood. We talked about it peaking and then it gradually declining throughout the pregnancy. Then we have relaxin. Relaxin is secreted by the placenta as well as the corpus luteum. It works with progesterone to maintain the pregnancy and causes relaxation of the pelvic ligaments. Also helps soften the cervix in preparation for the birth. Overall, relaxin just relaxes everything. So a pregnant person may be a little bit more flexible, a little bit more limber than they were pre-pregnancy. You also hear of patients getting diagnosed with carpal tunnel syndrome, again, because of the increase of relaxin, or lots of sciatic issues because things are relaxed and not as stable as they are in pre-pregnancy. It's also going to increase the flexibility of the pubic symphysis to allow for pubic opening for delivery, right? So relaxin plays a big role in a lot of things. Progesterone. It's produced by that corpus luteum during the first few weeks of pregnancy and then, again, replaced by the placenta. Often called the hormone of pregnancy because its critical role is playing in supporting the endometrium of the uterus. It decreases the contractility of the uterus, stimulating maternal metabolism and breast development, provides nourishment for early conception, and causes vasodilation. So that vasodilation is in return going to increase that blood flow to our fetus that needs it, right? Then we have estrogen. Estrogen works on enlarging breast tissue, the uterus, external genitalia, stimulates myometrial contraction. Something with this I always think about, a lot of times when a baby girl is born, her genitals are very swollen, and that's because of the increase in estrogen that has been passed on from mom to baby. So that's a way that I kind of remember in my mind what estrogen does.
Is that the same thing for male babies? Because like their testicles will be like very swollen as well.
Yes.
Okay.
Yeah. Because of that increase in estrogen.
Okay.
Mm-hmm. Sorry, lost my place. Also plays a role in relaxing those pelvic ligaments and joints. It's also associated with the hyperpigmentation and vascular changes of the skin. So that increase in estrogen can play a big role on some skin changes that we have, and we'll talk about that too. It also aids in the ductal system of breast development for preparation of lactation. So it does play a big role in breastfeeding. Then we have the HPL, the human placental lactogen, and it modulates fetal and maternal metabolism, participates in the development of maternal breasts for lactation, and decreases maternal insulin sensitivity. All right, so reproductive system adaptions. The whole reproductive system changes, right? It's growing a baby. And it's going to start with the uterus. What do you think the biggest change of the uterus is?
It's gonna get bigger.
Size, right? It's going to get big in order to hold a baby that's potentially, 12 pounds? Some people have 12-pound babies, but normally it's going to be like a 7-pound baby, right? So it's predictable growth over the course of the pregnancy, right? Like we know it's going to start small and then it's going to get bigger and bigger and bigger. So size actually increases 20 times that of a non-pregnant size. So it gets pretty big. Like a uterus is starting about softball size. Imagine that 20 times the size. Capacity increases by 500 times to accommodate the developing fetus. And the weight increases from about 2 ounces to 2 pounds.
What's your?
Uterine growth occurs as a result of both hyperplasia and hypertrophy of the myometrial cells. As the uterus grows, what do we think it presses on? The bladder, right. So the
And-
bladder gets squished, and that makes us have to pee a lot, right?
And also the inferior vena cava, right?
Yes, I was going to talk about that next, right. So the gravid uterus, and when I say gravid, I mean what? The pregnant uterus, so if you hear me say gravid, you know it's pregnant. Gravid, G-R-A-V-I-D. So that uterus with that big heavy baby, if I'm laying on my back, what's it gonna do? Press on my inferior vena cava, causing what? Potentially
Pre-eclampsia,
dizziness,
hypertension.
decreased blood flow that's resulting in low blood pressure, so that hypotension and decreased blood flow to
Baby.
the baby. So if I'm 40 weeks pregnant, should I be laying flat on my back?
Well, how are you supposed to lie?
On your left
On
side,
your
right?
side.
Left side.
Left side. It's left side.
Y'all ain't tricking me into this. I'm so sorry.
But yes, you don't want to lay on your back because you want to make sure you're getting plenty of blood flow to your baby. And that heavy baby and heavy placenta and heavy uterus will push on that vena cava and cause decreased blood flow. Her mind's blown over there.
Excuse me? Oh,
All right. So we talked about Gödel sign or Goodall sign. I'm not really sure how to pronounce that, really. I don't think anyone actually says it, but that it is a sign. So again, softening of that cervix, and that's important in the dilation of that cervix, right, for later on. Other changes, the endocervical glands increase in size and number, so it's going to produce more cervical mucus, so more discharge. Eventually forming a cervical
Plug.
mucus plug. What's the role of that plug? To prevent bacteria from getting in. So additionally, just overall discharge is going to also increase. And same thing there, just helping to kind of clean and prevent any infection in that area. Only time the discharge becomes a concern is if there's an odor, if it's starting to become itchy or irritable, because then I'd be worried about what?
Infection.
Yeast infection. Yeah.
Where does the mucus plug sit exactly? Inside the cervix or
Mhm.
underneath the cervix?
Inside the cervical os. So this is the outside of the cervix.
Yeah, that's
Okay, so this is the outside of the cervix. It's actually going to sit on the inside.
I was wondering how it was just gonna float up there.
Yeah.
No.
Yeah, so it's on the inside of your cervix. So it would be here between the placenta and the baby
Oh, like a
and the
plunger.
uterus. Yep. All right. So increased vascularity in the vagina, which leads to congestion and hypertrophy. Well, what does that mean? How does my vagina get congested? Like, is it stuffy or what? Like, I don't like that. So increased vascularity because of estrogen influences result in pelvic congestion and hypertrophy. So that's that increased thickness of mucus along with an increase in vaginal secretions. And again, helping to prevent the bacterial infections. So we call that thickened secretion leukorrhea. So just white, thick discharge. Again, only concerning if it's causing a problem. Yeast infections are very common though in pregnant women. So we do want to do some education about that. All right, ovaries. Our ovaries are going to increase in size because of the increase in blood supply. So this is typically going to happen about 12 to 14 weeks of pregnancy. It's also going to help with the production of all those hormones that they need to produce until the placenta takes over. They produce the hormones, especially progesterone, to support the pregnancy until that 6 or 7 week when that placenta does eventually start to take over. So otherwise they're coming from those ovaries.
Like, obviously the body just knows that it's like a smooth transition, but does that mean like the ovaries just stop once the placenta's formed?
No, I think they're still producing a little bit, but really the amount of progesterone is getting so high that the ovaries can't keep up. So they're producing a little bit, but the placenta ultimately is going to take over. Good questions. All right. Can't be pregnant without breast changes, right? So affected by the estrogen and progesterone that we talked about. One of the first things that's going to change in early pregnancy is breast size, breast tenderness, areola size, areola shape, all of that kind of stuff. Striae might be present. What's that?
Stretch marks.
Stretch marks. Wonderful stretch marks. Everybody loves those, right? So we might get stretch marks on our breast. The tubercles of Montgomery enlarge and become more prominent, and the nipple becomes more enlarged. So because of the blood vessels, increased blood flow to the breast, that's where that's becoming more prominent and more erect from. Women can also start producing colostrum early in their pregnancy. Some women earlier than others, right? It's a creamy yellowish fluid. It's what the baby's first going to eat when the baby's born. Typically, you don't really see it being expressed until about the 3rd trimester, but it can be sooner than that. And it can either be from some sort of like stimulation to the breast, or it could be, you press or had some sort of pressure on your breast and you leak. Or it could just be let down too. The milk just letting down, getting ready to feed for the baby. Okay. So, yes.
How come some people's milk never comes in after they give birth?
It can be a lot of different factors. It could be some sort of development issue. It could be hormonal, right? Maybe they're just not producing enough hormone. It could be the way the baby is trying to eat and they're not getting enough stimulation. So it can be a variety of factors. Okay. We're going to talk about other body systems. So the GI system, estrogen plays a big role on gum vascularity. So a lot of pregnant women will have bleeding gums. So really important that they're flossing and brushing well. And actually overall dental care or dental health changes during pregnancy. One, because of the estrogen, which also increases the saliva in the mouth. And with all that saliva and everything in there, can increase cavities and tooth decay. So making sure you're taking care of your teeth really well is important. And a lot of times, we'll talk about this on the respiratory slide, nasal congestion comes into play with pregnancy, so you get a lot of that mouth breathing too, right? So dental care, super important during pregnancy. And also, we're having some nausea and vomiting. So throwing up, but that acid can really destroy the enamel on our teeth.
And you also like just lose your teeth.
Yeah. Yeah. Some people do.
Okay.
Yeah.
Sucking up all that
I always
calcium.
had dreams that my teeth were falling out when I was pregnant. They never did. They never did. But you do want to make sure that they're following up with the dentist. What's the cause behind that? Like
Them losing their teeth. Why
Just
is that?
the decay and
Yeah.
Oh, okay. Yeah. So then the esophagus. So, we have a sphincter in our esophagus that connects from our stomach up, right? So that sphincter can soften and loosen, ending up in what? Acid reflux, right? And heartburn, right? And what do you think that why is that sphincter relaxed?
Relaxing.
Relaxing. Good job. See, you guys are listening to me. It's making me so happy. All right. So stomach changes also decreased tone and mobility with delayed gastric emptying, which increases the risk for the reflux and vomiting. Decreased gastric acidity and histamine output, which improves symptoms of peptic ulcer disease. Morning sickness with this, nausea and vomiting, 6 to 12 weeks typically. It typically resolves after the first trimester, but 80% of women have it in their pregnancy, so it's very, very common. I am one of the 20%. I did not have nausea and vomiting with either of my pregnancies, except I threw up one time with Ella in labor. That was it. I will do everything in my power not to throw up. I hate it. So, again, the nausea and vomiting is coming from all those increase in hormones, the estrogen, progesterone, and the HCG levels. But it also results in slowed peristalsis, right? So our GI tract is just moving slower overall, resulting in constipation. So constipation is a big side effect of pregnancy as well. Then we occasionally have severe hyperemesis gravidarum, which is severe morning sickness. I mean, debilitating, severe morning sickness.
Just real quick, do you have more of certain hormones if you're pregnant with a boy or girl? Or is that like a myth with the vomiting thing with the boy and girl?
So it's a myth when it comes to the boy-girl thing, but your hormones are different depending on your pregnancy with a man, a boy, or a girl.
Like you're in
Yeah. Because I can attest, it doesn't matter if you're a boy or a girl, because I wasn't sick with either. So, and like so many people that I know too, it doesn't matter. Like there's no rhyme or reason to it. But hyperemesis gravidarum does result in severe morning sickness. A lot of times these patients need PICC lines. For IV Zofran, they might be getting IV fluids. They may be in the hospital on antepartum for a few weeks or on a med-surg unit, depending on how far along they are. Can you think of a famous person that has had hyperemesis gravidarum? Oh, I think she did too. Yeah. I was thinking Kate Middleton. Yeah, she was really sick with her pregnancies. That will be a test question. Maybe it might be the bonus. All right, cardiovascular system. One of the most important things to remember, blood in a pregnant person almost doubles. Okay, so you have a tremendous amount of blood in your system. So our blood volume is going to almost double, which is going to do what to our cardiac output? Increase our cardiac output and our heart rate, potentially decrease our blood pressure, especially in the beginning of pregnancy. So our blood pressure is actually going to decrease in the beginning of pregnancy and then start to increase towards the end. And because our blood's doubling, our blood components, like our red blood cells, plasma, are also going to increase. This is a good picture of the vena cava, the inferior vena cava laying on your back. So you can see this person's laying on their back, squishing, squishing, squishing. You rotate to the side, no longer squishing, right?
Where are the organs at? Just up?
Up and around or down, right? So bladder's going down, diaphragm's going up, liver, gallbladder probably going out. So with our blood volume, we've got that marked increase in plasma and red blood cells compared to non-pregnant values. So this is going to cause hemodilution, right? It's going to reflect potentially in a lower hemoglobin and hematocrit in a pregnant patient. Cardiac output and heart rate. Cardiac output increases from 30% to 40% over the non-pregnant rate. The increase in cardiac output is associated with an increase in the venous return and the greater right ventricular output, especially in the left lateral side. So ideally, if we need to increase blood flow to the baby at any time, and we'll learn about why we might need to do that later on, we're going to always put them in that left lateral side because of the way the blood is flowing. Our heart rate increases by 10 to 30 beats per minute, and this will persist throughout the term of pregnancy. Again, blood pressure is going to decrease in that initial period, and then it gradually returns to non-pregnant values.
How much did you say for the heart rate?
Heart rate is 10 to
10%?
30.
Or 10 to 30 beats?
Mm-hmm.
Should we know the numbers for our
Know that the heart rate increases.
Gotcha.
I'm always, good thing for me, just to know about me, I want you to understand the concepts, right? Anybody can remember 10 to 30, right? That the heart rate's going to increase 10 to 30 beats. I'm not going to test you on that. I'm going to test you on the concept. Can you recognize what's happening in this patient? So knowing that a patient's heart rate is going to increase because of the increase in cardiac output, that kind of stuff, right? So you've got to think through these questions. There'll be more NCLEX style questions than recall. So more application type questions. Remember, you guys, we're prepping you to take the NCLEX. So we're going to have some harder questions for you guys.
Boy.
Okay. So, just like every other system, respiratory system's affected, right? We need more oxygen to deliver adequate oxygen to the baby. But that's okay because we know we have an increase in red blood cells, right? So we have overall the ability for increased oxygen supply. So, again, like Arne asked, where do the organs go? Well, these organs, the diaphragm, is going to shift upwards by 4 centimeters. So that lung space is actually going to decrease. As muscles and cartilages in the thoracic region relax due to relaxin, the chest broadens. And we're actually going to change from abdominal breathing to that more thoracic breathing, so chest breathing. So we're definitely going to start to breathe a little bit more shallow, right? So just overall, it's a little bit harder to breathe. So, will the shift in your diaphragm or the change in your breathing affect your lung sounds?
No.
Not necessarily, right? You might have to listen a little bit higher,
That's what, yeah.
but you shouldn't have advantageous lung sounds because of this, right? But we will have some upper airway issues. So mainly the nasal congestion, right? Because of the increased vascularity due to the estrogen and progesterone, resulting in that nasal congestion and stuffiness. What's something that we could potentially tell our patients to do to help with that?
Nitty pot?
Saline rinses, right?
Same thing, right?
What else?
Hot showers.
Hot showers, so that humidity, maybe having a humidifier or something in the room, or doing menthol, breathing, that kind of stuff.
Or the warm compress.
Warm compress, yep, absolutely. Should they take nasal decongestants?
Nope.
No, gotta leave those at home. Can they take allergy medicine?
Depends.
Yeah, it depends on the allergy medicine, but yes, you can take allergy medicine. a lot of times they tell you not, like on most of the lists, they'll say no Flonase or anything like that, but it's one of those things. Do the risks outweigh the benefits? Do I want you to breathe? Yes. Are there true good studies on the effects of Flonase in pregnancy? No. So if you think you need the Flonase, I'd rather you take the Flonase so you can breathe and your baby can get oxygen and overall everybody can be comfortable, right? Nosebleeds are also common in pregnancy. The rising levels of the hormones and heightened sensitivity to allergens can influence the nasal mucosa and overall the increase in vascularity too of the nasal mucosa.
So is that why like people say they have pregnancy nose and stuff like that?
Mm-hmm. Yeah.
Oh, that's weird.
Yep, exactly. We can have minor voice changes. Pregnant patients can also be difficult to intubate at times. Do you guys want to do a 5-minute break? Yeah. We go until 3, right? 2:50? Yeah, just take a 5-minute quick break. All right, so just so we can make sure we finish up on time and I can get through all of this. So we're going to have lots of changes in the renal system, right? We talked about the bladder changing because of the pressure in the uterus. But the renal pelvis also becomes dilated, and that's because of estrogen and progesterone. The uterus, especially the right ureter, and I don't really understand the full pathophys behind why it's especially the right ureter. I need to look that up. I didn't have time to do that. Elongate and widen and become more curved. And by that ureter becoming elongated, more curved, and widened, it's going to cause urinary stasis. So we've got the chance for increased pyelonephritis. Lots of pregnant women come in with pyelo and can get admitted to the med-surg unit or coming through the ED because of pyelo. So you could see them then. Pyelonephritis, obviously an infection, right? I did your kidney lecture, your renal lecture.
Yes, you did.
Yeah, I did. Bladder tone also decreases, but by term, the capacity doubles. So the tone is loose, and actually, Paul in the last section made a really good analogy. He's like, oh, it's kind of like a water balloon. So when you squeeze that water balloon, and it flattens out kind of like a pancake because it's lost its tone, but it still can have just as much fluid in it, right? Before it pops. So blood flow to the kidney increases by 50 to 80% as a result of the increased cardiac output. It's going to increase our GFR during the pregnancy, so you'll see higher levels of GFR. The activity of the kidneys normally increase when a person lies down and decreases upon standing. So that's why when a pregnant woman, as soon as she hits the bed, she's got to jump right back up and go to the bathroom. And maybe it's just me. Any night shifters in here? Yeah. Do you guys find that like when you try and come home from night shift that like as soon as you lay down you feel like you have to pee more?
Well,
No.
I paid all out. Battery acid because I was pissed for 12 hours.
Yeah. Well, when I worked night shift, I remember just like always like I would barely pee all night long and like drank anything, but as soon as I went to bed and laid down, like that's when I needed to pee. And it took me forever.
Interesting.
Yeah. But so that feeling is actually amplified during pregnancy, which is a reason pregnant women feel like they need to urinate while they're trying to sleep. Late in pregnancy, the increase in kidney activity is even greater when the woman lies on her side rather than her back. Lying on either side relieves the pressure that the enlarged uterus puts on the vena cava carrying blood from the legs. Subsequently, the venous return to the heart increases, leading to increased cardiac output. Increased cardiac output results in increased renal perfusion and the GFR. As a rule, all the physiological changes maximize by the end of the second trimester and then start to return to pre-pregnancy levels in the third trimester. However, the anatomy changes after pregnancy can take up to 3 months. So in the renal system, at least. Okay. So what happens when we get pregnant? We get a belly. And everything goes to crap, right? So our gait changes, our posture changes, we're gonna hold our weight more forward, which is gonna result in something called lordosis, which is that pelvic tilt, right? I'm gonna have that arch in my back all the time. And then even after I have my baby, I'm still gonna have that anterior pelvic tilt, and I'm always gonna have chronic back pain afterwards, right? Speaking from experience. So you're gonna have the lordosis. So you can see as the pregnancy increases here, you can see the curvature in the spine get a little bit more intense, right, as the pregnancy progresses. So our weight is going to be a little bit more forward. We might start to get that waddle. Our ligaments are really loose, so we're not as stable in our pelvis because of the relaxin. And we're an increase at fall risk, right? Because of all of that. We're also going to have some changes in our abdominal muscles. Our abdominal muscles have to separate in order for our abdomen to expand, right? So this is called diastasis recti. So you can see the abdominal two muscles start to separate. They do eventually come back together after pregnancy, or at least as close as they possibly can, but there may always be a gap there. And there's always a gap anyways, but might be a little bit of a bigger gap.
It takes it during the mommy with almost stuff in plastics. Like they do like the whole prototype, put it together.
Yeah.
That's it.
Put it back together.
Yeah.
Yeah. It would be nice. One day.
It's expensive.
I gotta pay for dog training. I don't have extra money. Again, usually restore the integrity, but sometimes an optional surgery, and doing, lots of core workouts after having a baby. Because of the relaxin, because things are not stable, and we're having so many changes, we've just got a lot of discomfort. Being uncomfortable in late-term pregnancy is normal. If you're comfortable in late-term pregnancy, that's maybe not normal. like you're one of the very few, but you're just going to be uncomfortable, and there's nothing you can do about it, right? There are belly bands that you can get to help kind of lift things up and relieve some of that pressure on your back, or relieve some of the pressure in your abdomen, to help make things a little bit more comfortable. But really, there's not too much you can do, right? Mobility is great, like doing yoga and getting into some different stretching positions to help relieve some of that discomfort. Working with a physical therapist, all of that kind of stuff could be helpful with any discomforts you're having. Okay, so we have skin changes. We've got changes to our skin, hair, and nails, sebaceous and sweat glands. So you're probably going to see an increase in sweating, some decline in hair growth, but a lot of women say like their hair grows like crazy when they're pregnant, and that's mainly because of the prenatal vitamins, right? So your hair is getting nice and long and thick and luscious. Your nails, pregnancy overall makes your nails a little bit more brittle and discoloration, right? Because all your blood flow isn't going to these places, right? But then you're combating it with your prenatal vitamin and your folic acid that you're taking, so sometimes it improves. We do get hyperpigmentation, and again, that's from that estrogen and progesterone, right? Those changes. So that hyperpigmentation can be discoloration in between your thighs, under your armpits, your areola, really anywhere on your skin. Then we have the linear nigra. That is that discoloration that you'll get from the pubic bone all the way up past your umbilicus. Again, from estrogen does go away after pregnancy. It can take like a month or two though to go away. Our stria we talked about, we know those are stretch marks, that red, sometimes bluish marks on your skin from your skin stretching and tightening. Melasma, again from estrogen and progesterone. This is sometimes referred to as the mask of pregnancy, just this dark discoloration that you get on your face. Sun can actually make it worse, so we want to make sure we're doing good SPF with this one, right? Really doesn't matter, darker skin, lighter skin, anyone can get it, okay? Then we have varicose veins. Why do we get varicose veins?
Because God hates us.
Oh, sorry. Increase in what? Vascularity, right. Commonly result in the distension of the veins, so that increased vascularity or increased blood flow, instability, and poor circulation. So, we've got this big uterus that's kind of still, even though we're not laying flat, right, but still pushing and impeding some of that blood flow from our lower extremities up. So that blood is just kind of pooling and collecting in our lower extremities. So what's something we could recommend to a patient who is suffering from varicose veins?
Compression stockings.
Compression stockings. Important to note, you can get varicose veins in other places than just your legs.
Where?
Your genitals.
Jesus Christ.
Mm.
Yes.
Oh.
No, actual like varicose veins around the vagina and in the labia majora. They are painful a lot of times, varicose veins are. If you do have them places other than your legs, there's not too much you can do about them. And after pregnancy, they're probably going to get worse from all that pressure that you put into your perineum pushing. Can be related to prolonged standing or sitting. Just the pressure of the gravid uterus also. Yeah. See, I'm making you guys all want to get pregnant and have babies, right? All right, so our endocrine system, lots of changes going on with that because the endocrine system's responsible for what? Hormones, right? We've talked so much about hormones. So it's going to control the integrity and duration of the gestation by maintaining the corpus luteum, right, which is in those ovaries. Via the HCG secretion, production of estrogen, progesterone, HPL, and other hormones. Even oxytocin, which is referred to as
Love drug.
the love hormone, right? So our thyroid gland enlarges and becomes more active during pregnancy. One, because of increased vascularity, and two, because of hyperplasia. Then we've got an increase in thyroid hormone. Starts during the first trimester and continues until shortly after. The maternal thyroid hormones actually pass to the fetus. And it's important in normal fetal neurological development, especially prior to 20 weeks. Our pituitary gland secretes prolactin and initiates lactation, those hormones needed for lactation.
What was the first one? Prostaglandin?
Prolactin.
Prolactin. Prostaglandin is inflammatory.
Secretes that oxytocin, which is important in establishing contractions in labor and initiating our milk supply.
Do they give that? I swear I got something like that to induce labor.
Yeah. Pitocin or oxytocin we give to induce labor, yep. Because oxytocin is going to help with those contractions. So a natural production of oxytocin could even be breast stimulation by like putting a breast pump on and trying to stimulate your breast to stimulate contractions to go into natural labor.
Recommended?
No, not really. I mean, the midwives might have you do it, but yeah. All right, the pancreas. Our pancreas does what?
Insulin.
Secretes our insulin, right? Insulin is needed for our baby, and to regulate our maternal glucose. So the insulin production decreases in the first trimester and then actually rises in the second. If we're deficient in insulin by that second trimester, you're probably going to get diagnosed with gestational diabetes. And that's a whole nother topic that we'll talk about towards the end of the semester. Then we have adrenals. So this is our increased aldosterone production, which is going to do what? What does
That's
aldosterone do? Okay.
it's the kidneys.
What am I
know
going to
that.
regulate with it?
Blood pressure.
Right. And then we're also going to produce cortisol, which has that anti-inflammatory effect. So, prostaglandin secretion during pregnancy. This is a chemical mediator or local hormone. Prostaglandins act locally on adjacent cells. The fetal membranes of the amniotic sac, the amnion, and the chorion are both believed to be involved in the production of prostaglandins. It is widely believed that prostaglandins play a part in softening the cervix and initiating and or maintaining labor, but the exact mechanism is unclear. So those prostaglandins, actually, we give prostaglandins to help soften or ripen the cervix to try and induce labor. And we'll talk about that when we get into labor and birth and stuff like that, but and why we give them and what kind of prostaglandins we give. So for future reference, not important, but no, insulin does play a role, glucose is important. We'll talk about gestational diabetes in a later lecture. Immune system. So our immune system kind of goes haywire, right? Our immune system's going haywire because we have a foreign parasite growing inside our body, right? So our immune system is going to go kind of a little bit crazy, so we don't try and reject the baby, right? So we're going to be more prone to getting sick. Really important for us to get our vaccinations, like our flu shot, if you qualify for pneumonia vaccine, your Tdaps, your COVID, now we have RSV vaccines, all of those kind of things to help protect you and your baby, right? Because your immune system isn't doing great right now. Also increasing the potential for that urinary tract infection. We know we have all that urinary stasis going on, but then also our immune system is lower, so increased risk for infection. Also varied response in terms of chronic disorders and autoimmune diseases. So a lot of times in pregnancy, this is when autoimmune diseases like to spike their nasty head, right? So you may have gone into pregnancy with no autoimmune disorder, but you might have gotten diagnosed with something during pregnancy or right after pregnancy. Or if you do have an autoimmune disorder, a lot of times they will increase in symptoms. All right, nutritional needs. Prenatal vitamins are prescribed to everyone who gets pregnant. You should take your prenatal vitamins if you're trying to get pregnant, if you are pregnant, and after you are pregnant. So, prenatal vitamins, again, routinely prescribed as a safeguard against less than optimal diets. With the exception of folic acid, there's little scientific evidence to support giving vitamin supplements to healthy pregnant women, but it does seem to be just the standard of care nowadays. Overall, we just want to encourage our pregnant patients to eat a healthy diet, right? Well-rounded diet, fruits and vegetables on at least half of your plate, good sized portion of protein to keep your energy up, replace saturated fats with unsaturated ones. Anyone who's been pregnant knows all you want are unsaturated fats, some good cheese fries. Even when I'm not pregnant, I want cheese fries or cookies. Whole grains instead of refined grains. Choose foods with lots of fiber because we know we're going to have some constipation issues. Don't consume alcohol. Limit your calories from added sugar. Use reduced fat spreads and dairy products. Consume at least 3 quarts of water. So you really actually want to kind of almost double your water intake. You do need to stay really hydrated. But also making sure you're getting plenty of electrolytes and not overhydrating. A lot of pregnant people will actually overhydrate sometimes. So some good special diet considerations, ensuring our gluten-free patients are getting what they need. Our cultural variation, so if they're not able to eat something specific or they are, really just eating fish, making sure that they're eating the appropriate fish, because I want to make sure that they're not eating fish that are high in what?
Mercury,
right?
yeah.
We have pica. So pica is that intense craving of something that's not a normal food, right? Chalk or nails or
Rocks.
yeah, just weird stuff, cornstarch, baking soda, that kind of stuff. Vegetarians, making sure vegetarians are getting enough protein and sources that they need. So staying away from fish, shellfish, and mercury. Listeria. What is the big thing that carries listeria? Lunch meat. Can I eat lunch meat at all if I'm pregnant?
Yeah.
Yes, I can eat lunch meat, but it has to be heated up for at least 10 seconds in the microwave. But I could go to Subway and get my sub toasted, still heated up, right, for at least 10 seconds, so I can eat that lunch meat. Wanting to make sure you wash your hands, refrigerate all perishable foods, don't eat soft cheeses. I just realized that I definitely eat that of my whole pregnancy and didn't even consider that a soft cheese. But I also eat deli food. I'm not a good pregnant person. Safe to eat canned fish like canned salmon or canned tuna, that kind of stuff, and shelf-stable seafood. You don't want to drink any raw or unpasteurized milk or eat any unpasteurized products. So psychological adaptations during pregnancy.
In general.
Pregnancy is a mind blow, right? So you may be excited at the beginning, you may be really nervous, really scared, maybe not really accepting of the pregnancy, or you might be over the moon about the pregnancy, right? So you're going to have so many different emotional reactions. Really important that we have a good emotional support person or emotional support just in our lives, right? Another reaction is, how am I going to afford this? Babies cost money, right? Going into labor costs money. You have to go to the hospital and give birth, right? That all costs money. Formula, diapers, all of that. So can I afford it? How am I going to work once I have this baby? Because I've got to find daycare. Can I find daycare? There's so many things that you're thinking about. In addition, we have all the physical changes that we're going through, and our body image may be suffering, right? We've got weight gain and nausea and GI upset. We have, in the second semester, acceptance and caregiver and support role. Like, okay, I'm going to accept this now. I'm going to be taking care of this baby. I'm starting to get really excited. But also, you've got the confusion. Like, why are there so many breast pumps? What am I going to do with this, right? Or why are there so many different brands of diapers? What's the best? It can all be very overwhelming and challenging. Then third trimester, the anxiety really sets in. Like, I'm going to have this baby and somebody's going to let me take it home from the hospital and take care of it, and I can barely take care of myself, right? So thinking about all of those. Also, just what's your role in labor and delivery? What do I do as a patient? Who's going to coach me through this? I don't know what I'm doing. How am I going to deliver this baby? And concrete tasks can be very overwhelming, like making sure that you've taken childbirth classes or you've got your nursery set up and having a baby shower and getting all the supplies and everything that you need ready to go. So it can be very overwhelming, but it can be a very exciting time. So pregnant people will go through lots of different emotions throughout the whole thing, right? And they may go from one great emotion right back to something else,
In the same day.
Yeah, in the same day. Hour. Yeah, in the same hour, right. Because those hormones, too, are playing a huge role in that. Okay, we got 5 minutes. Let's do a quick little case study. So, who's in OCCP this week with me? Okay, a lot of you. One of the resources in the OCCP tab is a GTPAL. If you're not in OCCP, I would recommend looking at that. So some things as labor and delivery nurses that we communicate is gravida, para, term, abortion, meaning miscarriage or induced abortion, and living. So we communicate that through GPTAL. And you can see here, this patient is G2, so gravida meaning pregnant. She's been pregnant twice. But para is 0, so she's delivered 0, right? Then we go over, this is typically like induced, and then it's spontaneous, so she's a 1. That means she's probably had a miscarriage or ectopic pregnancy, something like that. Living is 0. So her current pregnancy counts as her second. So she's had a miscarriage and she's currently pregnant, okay? So that's where a G2 is. Now you could have, let's say, I have a patient who's had 1 baby previously, she would be a G2P1. Or you could have someone who's G3P2 0 1 0. So pregnant 3 times, 2 births, 1 miscarriage. Sorry, this should be a 2. 2 living. Because then it gets really complicated if you throw twins in the mix. Because then you could go G3, P2, but living 3. So she's had twins. Okay, so look at that resource. Even if you're not in OCCP, I would just look at it so you can get familiar with it. Because it's kind of hard to wrap your brain around it at first. So anyways, SG is a 19-year-old college student. G2P0 with 1 SAB, spontaneous abortion, at 24 weeks. During her prenatal visit, she reports feeling the baby move every day. She asked you about the changes she's noticed during her pregnancy. Her first question is, there's a dark brown line on my abdomen. Why is it there, and will it go away?
Linea nigra, and yes, 1 month
All right,
after.
Raise your hand. Who wants to answer it? Lauren. For the estrogen, right? So is that a normal finding?
Yes.
Is it going to go away?
Yes.
Yes. After
1
pregnancy
month.
ends, right? Why am I having problems with constipation? What can I do to relieve my constipation? Should I take a laxative? Melissa.
She's having it because it's a normal thing with pregnancy, and she can increase her fiber, and she should not take it.
Very good. Why is it a normal thing of pregnancy? What's the reasoning for it? Hormones that are causing decreased peristalsis, right? I feel like my nose is always stuffy, but I have a head cold. I have a head cold. What's happening? Congestion. Okay. Speak up. Vasodilation, right? From all the increased cardiac output and all that kind of good stuff. So what can we do? What can we suggest to her? Saline rinses, humidifier, all that kind of good stuff. Is having a backache normal in pregnancy? Yep. All the changes. Can I take Tylenol? Yes, I can take Tylenol. Can I take ibuprofen?
No.
No. I have much more energy now. Why was I so tired at the beginning of my pregnancy? Because. Scarlett says because. Why? What?
Well, because your body's changing.
Yeah, your body's going through so many changes, right? Your body is literally exhausted. then we know in that second trimester things kind of start to regulate, kind of get back to normal, right? So things go crazy, and then as the pregnancy progresses, things start to kind of go back to baseline. Good. Questions, concerns, problems? Some key points at the end. You guys can look those over. My office hours are in the syllabus. If you guys need to meet with me